to Professor Luke Henderson. Luke is a professor in the Brain and Mind Center with a focus on imaging. He leads the neuroimaging lab, has been using structural, functional, and metabolic MRI together with EEG to explore central changes, particularly related to acute and chronic pain. He's currently looking at where the brain sites are where chronic neuropathic pain comes in, both in humans and preclinical models. He's going to tell us about how can we explore the transition from acute to chronic pain. Thanks very much, Luke.
Thank you. Thanks for the invitation. So I just want to actually take you through some of the experiments that we have planned. We've just got funding to do a whole bunch of studies over the last sort of 6 to 12 months, and I'm not going to present you with any new data. Maybe hassle me next year for some results, but I just want to take you through some of the experiments I'm planning. And these are experiments in collaboration with a number of labs at the BMC, most notably Professor Kevin Key, who's just moved to the BMC, and Dr. Austin. Also with the Lambert Initiative and Ian McGregor and Dr. Cairns, and also with Professor Chris Peck from Dentistry and Chris Vaughan over at the PMRI. So all of these experiments are collaborative experiments. So if there's anything wrong with it, it's their fault. If there's anything good about it, it's mine. So I just want to, whoops. Okay, so chronic pain following nerve injury is called neuropathic pain. It can occur accidentally, so you can get a spinal cord injury and develop a neuropathic pain condition. You can fracture a bone, you can have a nerve damage through a brachial plexus avulsion, for example, or even a stroke within the central nervous system can result in a chronic neuropathic pain condition. But it can also be planned. So we know that when you go in for surgery, there is a chance that you'll develop chronic neuropathic pain following things like amputation, hernia repairs, mastectomies, facelifts, or even a tooth extraction. And the rates are quite high. Most people will develop an acute pain condition after an accident or after surgery, and that's directly related to the injury. When that injury heals and resolves, the pain tends to go away and we go on living our life quite nicely. But in quite a proportion of individuals, the injury heals, but the pain continues. And it can persist for decades. And it can turn into really a chronic neurological condition. It has nothing to do with an ongoing injury itself. That injury is healed. And this can be quite a devastating condition. And unfortunately, it's poorly treated. About 16% of individuals with chronic neuropathic pain get some good pain relief with current therapies. Most people don't. And it's just not a sensory phenomenon. So it is just not about a constant perception of pain. The individuals have increased rates of depression. They're 2 to 3 times more likely to commit suicide. They have changes in sleep health. And they have changes in family and social relationships. So it's a very sort of sinister condition with no real sort of injury to look at. So some people really suffer quite extraordinarily with chronic neuropathic pain, and it costs about $70 billion a year to manage and unsuccessfully treat. Now, there are sort of a number of phases along the chronic pain road. There is the acute phase after an injury or after surgery that can develop and persist into a chronic pain condition. Now, many people have, including myself, have looked at the pathophysiology of well-established chronic pain. So that's pain that's been going on for 6 or 12 months, or in most cases, years or even decades. And these are generally cross-sectional studies. So we compare a group of patients or a group of animals with a group of controls, and we use a whole bunch of techniques to look at that sort of underlying pathophysiology. Mind you, there are lots and lots of studies looking at chronic neuropathic pain and the underlying neurobiological mechanisms, and we haven't really got that much further than we have 30 or 40 years ago. Anyway, so one real question is to explore the pathophysiology of well-established chronic neuropathic pain. That's one area that we're interested in. But the second area we're really interested in is the acute to chronic pain transition. So what is it about the brain and what are the series of events that occur that make somebody go from acute pain condition and develop a chronic pain syndrome. And what is it about those individuals that don't develop a chronic pain syndrome? What are the brain events that occur? And maybe we can get a handle into that sort of transitional phase to try and prevent the development of chronic pain rather than trying to cure it once we've got it. So that sort of acute to chronic pain transition is something that we're very interested in. And we're also interested in predisposing factors. We know that a certain proportion of people will develop a chronic pain condition after things like surgery. What is it about that person or that person's brain or periphery that predisposes them to developing a chronic pain condition? You can have a group of individuals having an identical surgical intervention, and some will develop chronic pain and some will not. So this sort of predisposing factors is something that we're finding that we're starting to explore. So firstly, I just want to take you through what we know, and it'll sort of inform us about where we're going. So we're looking at basically the pathophysiology of established chronic pain. So we know that noxious afferents come into the central nervous system. They terminate in the dorsal horn or the spinal trigeminal nucleus for orofacial pain. They travel up to the thalamus and up to the cortex. This is a very simplified version. There are multiple pathways, but this is sort of one of the major pathways. And we know that if you look at the studies that have been published, we know if you have a small stroke within the thalamus or spinal trigeminal nucleus, you can develop a chronic pain condition. So nothing's going on at the periphery. These are central changes. We know that if you take an individual who's got a peripheral nerve injury and develop chronic neuropathic pain, that they also get anatomical changes in the thalamus and the spinal trigeminal nucleus and dorsal horn. So there's some similarity between both the central stroke and a peripheral neuropathic pain condition. We know that you get changes in ongoing activity. You don't get increases in sort of the pain pathways, which is quite interesting, but you do get a decrease in thalamic blood flow in an area of the thalamus that regulates thalamocortical rhythm, or the way in which the thalamus talks to the cortex. And we know from very early studies that if you record directly from the thalamus, you get a change in the frequency or the firing pattern in chronic neuropathic pain patients. They get burst firing. And we know if you use an EEG that the individuals will get a thalamocortical dysrhythmia. So the way in which this pathway is working is altered. It's not increasing its overall activation, but it seems like the pattern of activity is changing. And so we know all this, but we don't really know why. But some information may be important. We do know that, sorry, I got one. This is not working too well. We do know that individuals with chronic neuropathic pain have chronic astrocyte activation at the spinal trigeminal nucleus and also in the dorsal horn. We know this from preclinical studies that have looked at spinal trigeminal nucleus and dorsal horn, but we also know it from post-mortem human studies. So individuals with chronic neuropathic pain for years will have chronic astrocyte activation in the dorsal horn. And that pattern of glial activation seems to be different between astrocytes and microglia. Microglia seem to turn on early and then turn off, whereas astrocytes tend to turn on a little bit later and they really persist. And we also know that astrocyte activation occurs in the same areas where you get an increase in very slow oscillatory activity. We know that astrocytes, when they're activated, can release gliotransmitters. We know that they can increase very slow oscillatory gliotransmitter release that can modulate neurons. And we get an increase in the same frequency of activity throughout the pain pathway in chronic neuropathic pain patients. So we really do think that there's an interaction between astrocytes and neural activity. And this is sort of the model that we're working on. We think that after an injury, you basically get an increase in chronic astrocyte activation at the level of the dorsal horn or spinal trigeminal nucleus. And that results in gliotransmitter release, which modulates neural activity, and you get a change in the pattern of neural activity, both at the dorsal horn, but also in the thalamus and potentially up into the cortex. And so the series of studies we're about to start is really to look at that interaction between astrocyte activation in particular and neural activity. And that's quite difficult, particularly doing that in a longitudinal manner. But we do have the tools to do it. So there is some old studies using a positron emission tomography ligand, which binds to MAOB, which is a marker of astrocyte activation. So we do have the ability to investigate astrocyte activation in living humans and in animals in a longitudinal manner or in a cross-sectional manner. And we've just got funding to start a collaboration with Anne Stowe and Steve Michael at the BMC to basically develop this ligand. And so really we're going to attack this in two ways. We're going to run a series of preclinical studies where we take a rat, we give it an infraorbital nerve chronic constriction injury, and this is a very standard way of inducing a neuropathic pain condition. The animal will display all the behavioural changes, changes in sleep, changes in sexual and dominance behaviour, changes in sensory thresholds. We then can put them in the micro PET MR scanner that we have down at the BMC in the basement there, and we can inject a radioactively labelled ligand and we can image astrocytes. And at the same time, we can image neural activity using the MR component of the machine. We can look at brain changes of anatomy, diffusion, and all sorts of things. And then we can take the animal out, we can perfuse the animal and do slice physiology with Chris Bourne over at the PMRI, and Professor Kevin Key can look at immunohistochemical markers of glia and neural activation, etc. So we can get a really good sort of picture of what's going on in an animal model. But we're also going to extend that into a human model. So we're going to take individuals with chronic orofacial neuropathic pain, we're going to inject the ligand, we're going to put them into a PET MR machine, we're going to image astrocytes at the same time, we can image neural activity, we can take them out and do an EEG and measure thalamic-cortical rhythm, and we can take bloods and look at peripheral immune markers, for example. So really this will give us a good handle on the interaction between astrocytes and neural activity, both in a preclinical model and also in humans. So that really gets at sort of the pathophysiology of well-established chronic neuropathic pain. But we're also interested in the acute to chronic pain transition. So how can we look at the transitional change in astrocytes and neural activity over time as the animal or as a person develops chronic pain? So the best way to do this is in our preclinical model. So we can take the rat, we can scan them using our micro PET MR prior to any type of injury. We can test the behaviour and bloods. We can then perform a CCI. The animal will develop a neuropathic pain condition. We can scan them at day 7, day 14, day 28. We can perfuse to immunoslice physiology, etc., etc. So we can really track the interaction between astrocytes and neural activity and brain anatomy, as well as bloods and behaviour, over time as the animal is developing chronic neuropathic pain. Now, the great thing about this is we can then start to try and modulate it. Whoops. So in collaboration with the Lambert Initiative, we can administer medications that we think will blunt glial activation, such as PEA, which is an endocannabinoid, and cannabidiol, which have known anti-inflammatory effects, and they can reduce, in particular, astrocyte activation. We can also give the animals minocycline, which changes microglial activation. So we can give that before the injury, or we can give it after they've developed chronic neuropathic pain. So we can determine how blocking or reducing astrocyte activation or microglial activation can affect both the development of chronic neuropathic pain in this animal model, and also how it will affect the interaction between glial and neural function over time. Now, we've also got some funds to look at modulating astrocyte activity in a clinical population. So this isn't longitudinal, but it's cross-sectional. But we know that if you have a spinal cord injury, there's a very good chance you'll develop a neuropathic pain condition, about a 30 to 40% chance. That is generally in the area of the body where you can't feel pain at all. So you have a phantom pain. It's excruciatingly painful, and most of the individuals would rather pain relief than be able to walk again. So we can put them in a MR scanner. We don't have an MR PET here when we're doing this study over at Neura, but we'll put them in the MR scanner, measure EEG and bloods, give them cannabidiol, measure them again, give them a placebo, measure them again. And of course, we're going to cross that CBD and placebo arms over. It will be a double-blind, crossover, randomised clinical trial. So we can really now start to look in humans the effect of modulating astrocyte function on both pain and also brain function. Okay. So that's looking at the acute to chronic pain transition, but just finally, I want to talk quickly about predisposing factors. So we know that when you go in for surgery, there's a chance that you'll develop a neuropathic pain condition. And that's even if you go into surgery without any pain. So there is even a 5% chance of developing a neuropathic pain condition after a tooth extraction. And about half of individuals that go in for a tooth extraction don't have pain. So it's not the presence of pain prior to that determines whether you develop the neuropathic pain condition after surgery. And we know that things like early life stress, there's some data looking at early life stresses, both in humans and in preclinical models, where early life stress predisposes you to developing chronic pain conditions in adulthood. So we can take our preclinical model again. We can scan our animal, look at astrocyte neural function, behavior bloods, etc. We can give them an injection of lipopolysaccharide, which gives the animal a very low-grade systemic inflammatory response. This is considered to be an early life stressor. We can then image the animal again, and we can look at what an early life stressor does with respect to astrocytes and neural function. We can then perform our CCI to establish a chronic pain condition, scan them at 7, 14, 28, and perfuse the animal and do immunohistopathology. So really, what we're trying to do is to build up this sort of integrated human and preclinical approach, where we're using both preclinical models of neuropathic pain as well as humans where we can, to look at the interaction between chronic astrocyte activation and neural activity, and also looking at things like glial inhibitors and early life stresses on the transition to chronic pain and how that affects astrocyte and neural interactions. And fortunately, this has all been funded, so hopefully next year we'll have some real data to talk about. Thank you very much.